We have studied in detail the medical nutrition therapy for diabetes. In this lecture, we will discuss other diseases in the endocrine system. Our focus will be thyroid diseases. We learned in anatomy and physiology that the endocrine system is responsible for secreting a lot of hormones. Based on the functions of these hormones, we can classify the major hormones into 4 categories. Number 1, hormones responsible for reproduction and sexual differentiation. Number 2, hormones responsible for growth and development. Number 3, hormones responsible for the homeostasis of the internal environment of our body. Number 4, hormones responsible for the regulation of metabolism and nutrient supply. In this figure, we can see that endocrine glands are scattered throughout the body. So they're not connected directly. In this sense, the endocrine system is quite similar to the immune system. Different glands secrete different hormones. Sometimes one single gland may secrete multiple hormones, as we'll see pretty soon in the pituitary gland. And sometimes a single hormone could be secreted by more than one endocrine gland. For all the hormones to have effects, the target cells need to have specific receptors to bind to these hormones. So no matter what cells we're talking about, as long as these cells have the specific hormone receptor, this particular hormone will have effect. That's why we were saying a single hormone may have more than one target cells. At the same time, a single target cell may also respond to more than one hormone as long as this cell has receptors for different type of hormones. Let's talk about the major glands in the endocrine system, in addition to the pancreas that we have discussed in diabetes lecture. Pituitary gland is located at the base of the brain, as we'll see here, this section. And to amplify, we'll focus on the right side of the figure. The gland actually has 2 separate areas, anterior and posterior pituitary glands. Although in the anatomy structure, these 2 sections are very close, as we can see, very close next to each other. They actually are considered as 2 separate glands because they really secrete different type of hormones. The anterior pituitary glands actually is responsible for the secretion of 6 different hormones, whereas the posterior pituitary gland is responsible for the secretion of vasopressin and oxytocin. Vasopressin, another term for this hormone, is ADH, antidiuretic hormone. So that's the one implicated in the fluid balance in our system. Therefore, it is an important hormone in regulating blood volume and blood pressure. And the function of anterior and posterior pituitary gland is regulated by hypothalamus. So this is also a very important organ that play pretty much a central command role in regulating a lot of the homeostasis aspect in the body. If we look at the hormones secreted by the anterior pituitary gland, we'll see, we mentioned, right, there are 6 different hormones secreted by this part of the pituitary. What we want to focus on are these 2. TSH, thyroid stimulating hormone, and ACTH, adrenal corticotropic hormone. So the term indicates that ACTH is a hormone that stimulates the adrenal cortex. We'll show a picture of that tissue pretty soon. So let's look at the TSH, thyroid stimulating hormone. Its function is to stimulate the thyroid, as the name indicates. And we know thyroid gland is responsible in secreting T3, T4, those thyroid hormones. And T3 and T4 are important hormones that regulate metabolic rate. So as we can see, the hormones from the anterior pituitary is really at a higher position in the hierarchy of hormones. So it is a higher level, it's above the thyroid gland in this case. So it will tell thyroid to secrete more thyroid hormone, and then that will have downstream effects at the target tissue. Same thing for ACTH. It is situated above adrenal cortex. It sends command to adrenal cortex to secrete more cortisol, which will also have a significant impact on metabolism. Other hormones secreted by the anterior pituitary include growth hormone and hormones related to the lactation and the pregnancy and menstrual cycle of the female, as well as if we talk about male, the development of their sexual organ. So as we mentioned earlier, a category of major hormones, they are responsible for the sexual maturity and reproduction. So adrenal gland, as the name indicates, actually it is above the kidneys. So in a sense, it's almost like a cap, kind of triangle shape cap on top of a kidney. That's why it's adrenal. So renal is a kidney. And if we dissect this gland, we can see there's an inner portion. It's the inner portion. It's called adrenal medulla. It's regulated by the sympathetic nervous system and is responsible for secretion of epinephrine, norepinephrine, and other catecholamine molecules. And the outer layer is called adrenal cortex. We can see the outer layer, and this is the inner layer. And the adrenal cortex is responsible for secreting more than 50 different types of adrenocorticoid hormones. And there are differences in the structures of these hormones, and as a result, they have a different specialty or functions in different tissue. Thyroid gland is relatively superficial if we think about the anatomy position. As the figure indicate, it's in the center of our neck. So this is the trachea, the major airway. So it's literally in front of the trachea, and it's below the larynx. And this bone, although this this figure shows a woman, but this bone, if we're talking about a male client, would be the structure known as Adam's apple. So we can see where the normal location of the thyroid gland would be. And we already mentioned there are two types of thyroid hormones, T3 and T4. Both are considered thyroid hormones, and both have a profound impact on metabolism. When thyroid functions are abnormal, we can have consequences either when it's too active, that's what we call hyperthyroidism, or when it's not active enough, that's what we call hypothyroidism. And it's very interesting if we look at the description of the causes and try to understand why the hormone profiles changes the way it does. So one thing to notice is that we could see the change of a TSH. Remember, this is a hormone called thyroid stimulating hormone from the anterior pituitary. So this is a higher level of hormone in charge of stimulating thyroid. Therefore, when TSH level changes, we may not have an abnormal condition or disease per se in the thyroid gland, but change in TSH will affect the organ, the tissue. So please keep that in mind. That's why if we suspect the person has a thyroid problem, in addition to checking T3 and T4, usually the physician will also check TSH because that could give us clues as to where the root cause of the thyroid problem is. Again, it may not be the thyroid gland itself. Let's talk about hypothyroidism. The definition of this condition is that it is a clinical state resulting from decreased production and secretion of thyroid hormone. So the problem is that the body does not have enough thyroid hormone, and because of the key roles played by the thyroid hormone in metabolism, therefore people who have this condition will have a lot of consequences related to compromised energy metabolism, and in certain cases their growth, their stature, their height, and also their intellectual development will be compromised as a result. One major cause of hypothyroidism is iodine deficiency. In advanced nutrition, we learned that iodine is the mineral required to make T3 and T4. Therefore, if we are deficient in iodine, the thyroid gland will not have adequate raw material to synthesize adequate amount of thyroid hormone. In addition to this, there are other conditions that could affect normal function of a thyroid and leading to hypothyroidism. For example, there is an inherited autoimmune disease called Hashimoto's thyroiditis. So this actually is a condition affects disproportionately women more than men. And as a result of this inflammation caused by autoimmune condition, then we will have a decreased thyroid function. And sometimes the patient's thyroid is destroyed, either by surgery, we could take it out, for example, thyroid cancer. If that's the case, we want to take it out. Or in certain thyroid cancer or hyperthyroidism, we will use radiation therapy. That could destroy the target tissue, lead to hypothyroidism as well. And there are medicine and nutrient interactions going on. And also, please pay attention to these two. These two conditions represent the scenario where thyroid function could be compromised, but the root cause actually is above thyroid gland. It could be in hypothalamus. It could be at pituitary gland. So make sure to review the influence of TSH on thyroid function. When people have hypothyroidism due to the altered metabolism, they may have edematous infiltration in heart tissue. We know our cardiac muscle is responsible for rhythmic pumping so that blood can be supplied to the rest of the body. But the presence of this edematous infiltration between cardiac muscle fibers actually could affect the contractility of the cardiac muscle. So patient will have a compromised cardiovascular system. And also, there will be signs and symptoms and consequences in the GI system. For example, chlorhydria. So this condition refers to the inadequate synthesis of hydrochloric acid in the stomach. We know that is a key component in the stomach secretion that helps kill germ, denature protein, and among other functions. At the same time, patient may have increased intestinal transit time with gastric stasis. So that's something that could reflect in irregular or abnormal bowel movement. In the reproduction system, people with hypothyroidism can experience delayed puberty. For girls, they may have an ovulation, and for women, they may have irregular menstrual cycles. And for both male and female, they could have resulting infertility. In addition to all these consequences, all the complications in different systems in the body, patients with hypothyroidism may also have increased total cholesterol and LDL level and increased insulin resistance. So metabolism really is affected in many aspects. So what are the signs and symptoms? Some people may not have any obvious sign or symptoms, and some may have symptoms, but they are not specific for the most time. For example, people due to lack of T3, T4 will have reduction in metabolic activity, and we know when we have a decreased energy expenditure, we will have more energy saved in the body. That means people may have weight gain, and this weight gain sometimes is not able to be explained by any other reason. The patient may come to us saying, really, I have been exercising the same way, I have been eating the same way, I just don't know why I've been gaining weight, and no matter what I try, it doesn't go down. And we know the pathophysiology in hypothyroidism is that the metabolic activity is decreased, and we know when we metabolize the macronutrients, about half of the ATP, or the energy generated, is dissipated as heat, which is very useful in maintaining our regular body temperature. So when the metabolic activity decreases in hypothyroidism, the heat production is reduced as well. Therefore, many patients complain that they have intolerance of cold. They always complain about the temperature being too low. At the same time, they are easily fatigued. They also suffer from a slow mental responsiveness and slow reflexes and movement. They will have pitting edema in the lower extremity. At the same time, a lot of the patient will develop enlarged thyroid gland called a goiter, as we can see in this picture. The reason behind this is that when the thyroid gland does not produce enough thyroid hormone, our system will sense it. Okay, we don't have enough T3 or T4 in the system. Then that will actually stimulate the increased secretion of a TSH, because the TSH as a higher level officer, if you will say, okay, thyroid gland, you need to secrete more thyroid hormone because the whole body doesn't have enough. And one thing TSH does is to stimulate the growth of the thyroid gland. So if this condition is not corrected over a long time, there will be an overgrowth of the thyroid gland. The result of it is a goiter. And we can see how big this enlarged thyroid gland is. In severe cases, goiter could be so big, and it could even potentially crash the airway of the patient. Remember, thyroid is located in front of the trachea, so that could be a cause of airway obstruction. To treat this condition, we have to provide thyroid hormone. So that's an exogenous thyroid hormone. It's one type of a hormone replacement therapy. So until the hormonal status is normalized, really a lot of these symptoms won't go away. And when it comes to nutrition therapy, we need to check if there is a iodine deficiency. Obviously, the deficiency itself could lead to hypothyroidism, and if deficiency does exist, we need to correct it for sure. And because patients will take a lot of medications, and remember, some medications may cause hypothyroidism, so we need to keep in mind that we have to assess drug-nutrient interactions. As I mentioned earlier, a lot of the patients with hypothyroidism, they are not satisfied about their weight status. They complain about weight gain for no reason. And we already know this is the result of inadequate thyroid hormone levels. Therefore, until the hormonal level has been corrected, the regular strategy we have learned in weight loss won't work very well. In fact, I actually consulted an elderly female client once, and she was very dissatisfied about her weight loss rate because she was in competition with her sister, and they both signed up for Weight Watcher. But after the initial few weeks, she stalled when it comes to weight loss. Then once I learned that she had been having hypothyroidism for more than 40 years, I referred her back to her physician to check if the hormone therapy was still at the right dosage. So really, we have to make sure that is at a normal stage before we can go on to other aspects of therapy. Therefore, keep in mind, coordination of care is very common for patients with hypothyroidism. Contrary to hypothyroidism, hyperthyroidism is referring to the excessive secretion of a thyroid hormone. And there are many causes of this hyperfunctioning thyroid gland. And the most common cause is called Graves' disease. Graves' disease is an autoimmune thyroid disease. So Hashimoto disease is also autoimmune disease. So, but please make sure we understand Hashimoto disease leads to hypothyroidism, whereas Graves' disease leads to hyperthyroidism. And we are putting this big figure flowchart of the anterior pituitary hormones again, so that we can see the place where TSH is above the thyroid gland. Therefore, abnormality above the thyroid gland, either in hypothalamus or in anterior pituitary, could affect thyroid hormone function. We mentioned that Graves' disease is autoimmune. Patients with this condition will have in their circulation antibody called thyroid stimulating immunoglobulin, TSI. So TSI mistakenly targets TSH receptors on thyroid cells. We know for thyroid cells response to TSH, it has to have a TSH receptor. But now that the TSH receptor is destroyed by TSI, then TSH won't have effect on it. But TSI can stimulate both the secretion and growth of the thyroid. So it's pretty much kind of pushing out TSH and replace it to take its place. But TSI is not a TSH. The stimulation of a thyroid gland by TSI is not subject to feedback inhibition. Therefore, this kind of stimulation is unchecked. So that's why it will go out of control. With the hyperfunctioning thyroid, too much thyroid hormones in the system, patients will have the following clinical signs. So they have a palpitation, they feel nervous, they sweat a lot, and they suffer from hyperdefecation, and they have a heat intolerance. Recall that in hypothyroidism, patients have an intolerance of cold. Here is the opposite because we have too much thyroid hormone and we metabolize the nutrients too fast. Therefore, we have a lot more heat to dissipate. Therefore, really, we feel always feel hot. The patients feel hot. And also, contrary to hypothyroidism, patients, because of the increased metabolism, often have weight loss. And they, of course, eat a lot, but still they experience weight loss. And at the same time, they may have sinus tachycardia, so their heart rate will be too fast. And they have drooping eyelids and bulging eyes. So please look at this picture of a female patient with hyperthyroidism. So obviously, yeah, these part, the eyes and the eyelids, they are not normal. So almost we say in medicine, we always say it looks as if they are shocked, stunned, or they always look angry. And in addition to these clinical manifestations, patients may go through what outsiders would consider a personality change, because in addition to nervousness, they may become paranoid. For example, they may think other people are talking behind their back about them, and they are getting easily irritable, and they couldn't sleep very well. The medical treatments of hyperthyroidism include surgery. We can use thyroidectomy to remove partial thyroid gland. And we can also use antithyroid drugs to really make the thyroid less active in synthesizing and secreting thyroid hormone. Or we can use radioactive iodine therapy. So we will use radioactive iodine, then inject it into the patient's system. And because iodine is a required raw material for thyroid hormone synthesis, therefore iodine, once inside the body, will concentrate in the thyroid. Therefore, it will have a minimal effect of other tissue. But do recall, all these could reduce hyperthyroidism, but it could overcompensate, or over long time, it may come up as hypothyroidism. Therefore, for patients who have hypothyroidism, we need to ask if they had received any of these therapies in the past to treat hyperthyroidism. There's really no special diet to follow for patients with hyperthyroidism. And because a lot of medications are involved, we just need to check to make sure we are addressing drug nutrient interactions when they're present.